Now let's move on to the last part of the intracorpuscular defects, which are the hemoglobinopathies. You know I'm going to discuss sickle cell anemia and thalassemia under it, but first you need to know what a normal hemoglobin is. So majority of the hemoglobin that we have, 95% and above, is going to be the adult hemoglobin. Adult hemoglobin is made up of alpha 2 and beta 2 chains. Adult hemoglobin, alpha 2, beta 2. Other than that, we have a very minor quantity of HbA2. A2 is usually less than 3%. Usually less than 3%. Very tiny amount. It is alpha 2 delta 2. It is alpha 2 delta 2 that you have. And what is the last one that you see in newborns? Fetal hemoglobin. Fetal hemoglobin is alpha 2 gamma 2. So yes, now first learn these and then I'll go on to the hemoglobinopathies. So adult hemoglobin, 2 chains of alpha, 2 chains of beta. A2 is going to be alpha 2 delta 2 and fetal is alpha 2 gamma 2. Now I start with the hemoglobin disorders, and which are first one that I'll be discussing under this is going to be sickle cell anemia. Now when I say sickle cell anemia, the first thing that you have to know is mutation. So this happens to be a point mutation, means the problem is going to occur at one point. And not only so, at one point matlab this point, the problem that occurs is at beta 6 position. The problem that occurs is at a beta 6 position. And what is that problem that occurs? And that is the glutamic acid. The glutamic acid is going to change to valine, and many students get confused what changes to what. Glutamic changes to valine, valine changes to glutamic. That confusion happens in the paper. So remember, glutamic acid will go away and valine is going to be welcomed. Glutamic acid will go away and valine is going to be welcomed. That is what you have for sickle cell anemia. That is what you have at the beta 6. So see, this is at one point. That is why it is a point mutation. And what has happened because of that point mutation? That normally when glutamic acid was there, patient had what hemoglobin? Patient had adult hemoglobin. Now when it changes to valine, the patient is going to have which hemoglobin? The patient is going to have sickled hemoglobin. So has the sense changed? From adult hemoglobin, we've changed to sickled hemoglobin. The sense has changed. So what kind of a point mutation is it? It is a missense point mutation. Go back to your genetics. I have taught you the different types of mutations. It is a missense point mutation. Moving on to the next, before I start discussing this in a lot of detail, I just want to tell you that the same glutamic acid, if the same glutamic acid at the beta 6 position changes into something called lysine, that is going to be known as HbC hemoglobin disorder. That is known as HbC, and I'll show you. This is how the HbC crystals look like. This is something that I'm telling you for your higher institute exams. This is how the HbC crystals are going to look like, and I've told you at the beta 6 position, the glutamic acid over here changes to lysine. So this is different. What I'm talking about over here is sickle cell anemia, where glutamic acid changes to valine. Glutamic will go, valine will be welcome. That is at the beta 6 position. What are the factors that result in sickling? So the amount of HbS and the amount of HbA is going to make a lot of difference. So for example, I say that more the amount of HbS, common sense, more the amount of HbS, more is going to be the sickling. Of course, I mean, there's no rocket science in it. It's a common sense. More the HbS, more shall be the sickling. Next, amount of fetal hemoglobin. Now, I just want to tell you one concept over here before I get on to this rest of the story is that sickled cells, which look something like this, they have ultimately come from normal looking cells. Normal looking cells are going to change into sickled cells. You know whenever there is a decrease in the oxygen, matlab there is a case of hypoxia. Whenever there is a decrease in the pH, matlab there is a case of acidic environment. Whenever there is a decrease in water matlab dehydration. So these are the situations in which the sickling will happen. So if I say dehydration hai, so this is going to result in more sickling. Fine. If I say there is a case of hypoxia, of course, you will say less oxygen matlab there is going to be more sickling that shall take place. Next, if I say pH, I will say as the pH becomes decreased, there is acidic pH, there is going to be result in more sickling. So I think this aspect of it is done. Now, I ask you, what about the amount of fetal hemoglobin? What does fetal hemoglobin do? Go back to your pediatrics and fetal hemoglobin का oxygen affinity कैसा होता है? How is the oxygen affinity of fetal hemoglobin? The oxygen affinity of fetal hemoglobin is very, very high. It is going to keep a lot of oxygen affinity. So when oxygen is in abundance, are you going to have sickling then? No. This means that there is going to be less sickling, because there's a lot of oxygen that the hemoglobin is going to bind onto. So there is going to be less sickling. Coming to the last one, what if you have a double problem? Patient has sickle cell anemia also. Patient has alpha thalassemia. Thalassemia is what I'm going to tell you in a while. Tell me, alpha thalassemia mein to the alpha chains are only not there. The alpha chains are only not there. When alpha chains are only not there, obviously that means that the hemoglobin amount is low. है ना? If alpha chains are not produced, alpha to beta 2 में alpha chains are not produced, then the hemoglobin amount is low. Now when the hemoglobin amount is only low, then what sickle will form out of it? Obviously, so when the hemoglobin is only low, so what sickle will form out of it? So the sickling is going to be less. So please remember, only in case of some other hemoglobin like a fetal hemoglobin or in case of alpha thalassemia is there going to be less of sickling. Otherwise, if the hypoxia happens or acidosis happens or dehydration happens, all of those are going to result in proper sickling. So now let me tell you the types. The types include, what is this person? This person is going to be what? Normal hai, sickle hai, kya hai? Normal na? HbAA, adult hemoglobin. Adult hemoglobin means he's totally normal. If I say I'm dealing with someone who is HbSS, homozygous, heterozygous, SS, same. This is a homozygous situation. Homozygous situation basically means that this is a case of sickle cell anemia. But if I say I have a patient who is HbAS, little bit of adult hemoglobin, little bit of sickled hemoglobin, alag, A and S, separate, that is going to be a heterozygous. That is referred to as a heterozygous, and this patient is a sickle cell trait. Please note, sickle cell trait is when there's a heterozygous condition. This patient will have some changes in comparison to HbSS, which is sickle cell anemia. So what kind of, when I start using the word traits and carrier and all of that, what inheritance do I talk about? Does sickle cell anemia and even going forward thalassemia, do these all have autosomal recessive inheritances? Yes, I have taught you that in your genetics wala chapter. Yes, they have autosomal recessive inheritances. In fact, let me tell you, there is something a little advanced for the advanced exams. There is something known as compound heterozygotes. Compound heterozygotes means, heterozygous to I know, heterozygous matlab one is adult hemoglobin, one is sickled. So matlab one is normal hemoglobin gene and one is sickled hemoglobin gene. That is a different. But when I say compound, both the genes are going to be bad genes. One of them is going to be sickled, one of them is going to be beta thal. So for example, they say there is a patient who is beta thal and sickled. Beta thal and sickle, you'll say isme bhi problem. They are different matlab means they are heterozygous, and more so both of them are problematic. This means this is a compound heterozygous. When one was normal gene and one was a problematic gene, it was just heterozygous. But when both of them are different and both of them are problematic, that is a compound heterozygous. So these variations are also noted. Moving on to the next. What is all of these clinical features that I have written over here? Why so many organs getting affected? What is the pathophysiology behind it? So please note in this. So first let's understand what exactly is happening in the pathophysiology of sickle cell anemia. As I said, when I'm dealing with sickle cell anemia, to begin with, the cells are going to be just like regular looking cells that all of us have, the ones with a central pallor. But I have told you that as soon as some situations will happen, like there's a decrease in oxygen or there's a decrease in pH or dehydration or all the situations that we studied, suddenly I realized that these cells are going to change into sickled shapes. But please note, immediately they are not just going to become sickled for once and sickled for a lifetime. No, I'm going to change the direction of the arrow. That means that when the oxygen or the pH would be low, they will change into all these sickle things, and when the oxygen and the pH would come back to normal, when the oxygen and the pH or whatever situation you're talking about will come back to normal, they'll come back to their normal size and normal shape. So I realize this is a reversible sickling that is happening. This is a reversible sickling. So there are many cycles of reversible sickling that happens until one day when the cells say, I give up. Now I can't keep doing this to and fro, round and sickled. Now I'm going to become once and for all sickled, and that is going to be the end of the story. So when there is going to be multiple cycles of this happening, they ultimately end up becoming irreversibly sickled. Basically, the membrane cannot take so many changes. Now it becomes irreversibly sickled. Very, very important. So reversible sickling initially, irreversible sickling later on. So now in the end, all your cells are going to look like this. And you know, sickle cells have a property. Listen to me very carefully. S for sickle, S for sickle. The next S that you're going to have is going to be, they are very, very sticky. They are very, very sticky, means they will all stick to each other. Think logically. They have all gotten stuck to each other. They are very, very sticky. So what do you think is going to happen? If they are passing through a big blood vessel, not a problem. But if they are passing through a narrow lane like the spleen has very narrow blood vessels. The fingers have very chota capillaries. They have very narrow blood vessels. If they are passing through really narrow lanes, what is going to happen then? They will get stuck. What is that going to result in? It is going to result in crisis. Vaso-occlusive crisis. And that is why I have written so many of these things in front of you. Why? Because these are all the organs which will be affected by the vaso-occlusive crisis. Before I come down to the vaso-occlusive crisis, please note that the main clinical features, it is a sickle cell anemia. Sickle cell anemia means there's going to be pallor, of course. Also, I've told you it's a kind of an extravascular hemolysis, means who is going to break it? The spleen is going to break it. So, spleen is going to break it, matlab there is splenomegaly, and once the red blood cells will be broken, there is increase in bilirubin, that is jaundice. That is a part of every extravascular hemolysis. What is special about sickle cell anemia is going to be what I've been telling you, the vaso-occlusive crisis. The vaso-occlusive crisis. And imagine if there is a bunch of these sickle cells that goes and gets lodged in the brain, what is the patient going to result in? The patient is going to result in stroke. If it goes into the heart, patient is going to result in myocardial infarction. If it goes into the lungs, there is something known as acute chest syndrome. There is going to be acute chest syndrome. If it goes into the bones, of course, think of bones. Bones mein kaun sa bones? Bones mein, when we talk about, say, first let's start with vertebra. Let's start with vertebra. There's a very, very famous thing which is known as the fish mouth vertebrae. There is a fish mouth vertebrae that you see anywhere else in radiology where you see fish mouth vertebrae. One is fish mouth vertebrae in sickle cell anemia. You also see it in osteoporosis. Osteoporosis also shows you fish mouth vertebrae. But I want to ask you one more thing. Where do you see fish mouth valve? Anyone who can tell me? Where do you see fish mouth valve? Try to put a little bit pressure onto your brain. You will see in case of rheumatic heart disease, chronic rheumatic heart disease, you had seen fish mouth valve. Over there I had asked you, where do you see fish mouth vertebra? That is where I've come to today. Fish mouth vertebrae is seen in sickle cell anemia and osteoporosis. Okay, now let's talk about other bones. When it goes into the femur, in the femur there is going to be avascular necrosis. Avascular necrosis at the neck of the femur is very common in orthopedics you study. In the digits are to bichara very, very patla, very, very thin blood vessels are going to be there. Na? So there is going to be acute dactylitis. There is going to be acute dactylitis when this gets lodged in the fingers. So basically wherever it's getting lodged, it's creating a problem. That is a vaso-occlusive crisis. So is that the only crisis? No. Sickle cell anemia, vaso-occlusive crisis, so I was expecting. But what are the other crises that I can think of? The other crises are aplastic crisis, which I have read earlier. Whenever in hemolytic anemia there is an aplastic crisis, it is because of which infection? It is due to or associated with parvovirus B19 infection. Whenever there is a hemolytic crisis that everything has broken off, that is associated with which virus? It is associated with Epstein-Barr virus. Same things I taught you in your hereditary spherocytosis also. Na? Next, whenever there is sequestration crisis are what? All the sickle cells get sequestered in the spleen. All of them go and get sequestered in the spleen. Please note, for that matter, spleen is going to be really essential over here. Meaning what? When I'm talking about the spleen, initially you said that, ma'am, it was doing extravascular hemolysis, it was becoming big and all. But after some time, when these bunch of cells will start damaging the spleen, they'll start clogging the spleen. Is this going to result in multiple splenic infarcts? After some time, the spleen will only start getting attacked. There are multiple splenic infarcts. The spleen will start decreasing in size. Automatically, the spleen will start decreasing in size, and that is known as autosplenectomy. splenectomy. Now this is something that I want all of you to give extra attention towards, that once the spleen has lodgement, like sequestration crisis occurs, they go and sit in the spleen is gradually going to shrink in size, automatically it is going to reduce. Autosplenectomy. So initially to yeah, there is splenomegaly because the spleen is doing more work, but once these red blood cells start becoming clogged and occlusive, they are going to result in autosplenectomy. Very, very famous question. Autosplenectomy is seen in sickle cell anemia. Clinical features done. I hope everyone's confident. We can move on to the diagnostic part of it. When I'm talking about sickle cell anemia, for obvious reasons, the hemoglobin count is going to be low. The hemoglobin will be low because it is an anemia. And if there is an anemia, your bone marrow will always try to do more work, which tells you that the reticulocyte count is going to be high. Then we say, what about bilirubin? Of course, it's an extravascular hemolysis. If blood is breaking down, the bilirubin will increase, jaundice is going to happen. Till now, everything was going on common sense. Now let's talk about what is ESR going to be. Please note, when I'm talking about ESR, erythrocyte sedimentation rate, so tell me, till the time the cells were normal, they could fit into each other, pack and come to the bottom because they were shaped in such a way that they'll pack into each other very well. Now the cells have become all random sickled shape. Will they pack into each other properly and will they be able to come down, settle down normally? No. So the ESR is low. These cells do not pack and settle well. They do not pack and settle well because they are all weird shapes. They won't fit into each other. They won't settle to the bottom. So the ESR is going to be reduced in sickle cell anemia. Please remember, ESR is going to be sickle cell mein reduced. That is how you learn it, that the ESR in a case of sickle cell anemia is going to be reduced. Now let's see further. If I do a blood sample, what are these cells? These cells are referred to as the sickle cells. These cells are referred to as the sickle cells. Remember, the other name for a sickle cell is a drepanocyte. It is referred to as a drepanocyte, and sickle cells or drepanocytes that you have, they are only seen in case of sickle cell anemia. They are only seen in sickle cell anemia. Means, will they be seen in sickle cell trait? No. These are not seen. Make it in bold letters. These are not seen in sickle cell trait. They are only and only seen in sickle cell anemia. So is this the best modality to do? Just do a blood test and find out. See, if you do a blood test and you see these cells, then to you are sure that it is sickle cell anemia. Very good. Very good for diagnosis, not for the patient. But you know that this is sickle cell anemia. But if you don't see these cells, now you don't know, is it a case of sickle cell trait? Is he normal? Kya hai? So you are confused. You will have to do some other test. What is the test that you will do? You will do something known as the sickling test. Right? They are known as the sickling test. So what is the sickling test? All of you are going to take one slide like this, and very few times in pathology I have taught you the procedure of something. Here I want you to know step by step because they go into the nitty-gritties and details of it. So when I'm talking about a sickling test, they will say that this is a slide. On that slide you will take 1 drop of blood. So remember, you're going to take 1 drop of blood from the patient, and to that you will be adding 1 drop of something else. And what is that chemical? 2%. This chemical is asked a lot. Sodium metabisulfite. Either you can use sodium metabisulfite or you can use sodium dithionite. Dono yaad karna hai. You have to learn both dithionite or sodium metabisulfite. Either ways you use a 2%. Why are you using this? Because this chemical is very famous for removing oxygen. Now you are trying to act smarter. Sickle cells are trying to act smart, but we are smarter. Sickle cells say that I am not, like if you have a case of sickle cell trait. Sickle cell trait says, I will not show you these kind of cells. I will to look normal. You will say, wait, I will now reduce your oxygen. You will automatically start looking like sickle cells. If he is trying to act normal and if he is trying to show you these round cells, you will say, wait, let me remove your oxygen. Then I'll see how you look normal. As soon as you will remove the oxygen, these cells will start looking like this. So that is what you're doing. How are you removing the oxygen? You're adding a chemical which sucks out all the oxygen, sodium metabisulfite or sodium dithionite. And what concentration do you use it on? You use it at a 2%. After that, you'll say that, ma'am, very good, you have tricked the sickle cells. Uska oxygen le liya, and then he had to show his true colors. He was trying to show round, but now you've taken the oxygen, it has become sickled. But there's a flaw over here. What about the oxygen in the air? That was not blocked. So then you had to cover this. you are going to put a cover slip. You are going to cover it with a cover slip. Why? Because you want to cut out the ambient air, the oxygen around it. So you just don't place the cover slip like this. Nahin. You're going to place it and then you are going to seal it all around. Matlab double, triple, quadruple check. Cover slip lagaya, uske upar you seal it. How do you seal it? This is going to be sealed with, ideally, I'll tell you, this is sealed with paraffin wax. This is going to be sealed with paraffin wax. But many a time you might not have wax. But pathology is a department where you'll definitely have a lot of women and girls. है ना? तो girls के पास nail polish मिलेगा. So either it is sealed with paraffin wax or it is sealed with nail paint. So you put nail paint around it. ठीक है? तो you put nail paint, it's the same thing ना. Nail polish or nail paint, either concept is that you need to seal the surroundings so that no oxygen from the air can come. So now I have taken all the air inside by this chemical. I have blocked all the air from outside. Now will that cell have to show its true colors? Yes. And I saw that all these cells had started turning sickled. But it's a very good test. Sickling test is a very good test. But tell me, sickle cell anemia will also show you sickle cells. Sickle cell trait will also show you sickle cells. Can you differentiate? Is it an anemia case or is it a sickle trait case? Can you also quantify how much of sickle cell hemoglobin is there? 40%, 60%, 80%? No, only plus minus. Very primitive test. Similarly, there's another very primitive test that is known as the solubility test, because now I'm going to add one more S in your story. When you are talking about sickled cells, you realize that not only are they extremely sticky, but they are also going to be less soluble. They are going to be, their solubility is low. That is how you can learn it. Their solubility is also going to be decreased. Their solubility is also going to be decreased. What do I mean by that? Let's do a recap of it. Not only are they sticky, but their solubility is also low, which means that when I take the blood and I will add again, now this time I'm doing it in a test tube. I'm using the same chemical, sodium diethionate. What will sickle cells do? This time I'm doing it in a test tube. Now if I add blood over here and I add sodium diethionate, ठीक है, क्या करा? You added blood and you added sodium diethionate. These sickle cells will make polymers. Sickle cells form polymers. You will suddenly, if sickle cells are there in the person's blood, they will form polymers like this. Will the sample start looking very, very turbid? Yes. There is turbidity that you see in the tube. There is a turbid tube that the blood will start looking very turbid because polymers ban gaya. Aggregates have formed, and that is said to be the solubility test. So what are the two screening tests? One is the sickling test, on which you are definitely going to get a question. Very, very, very important sickling test, and the other one is going to be the solubility test. Done, but these were all chota tests. They are not solving the purpose. They are not telling me anemia hai, trait hai, percentage. So now I have to do a little bigger test, and that is known as hemoglobin electrophoresis. Now what is hemoglobin electrophoresis? Please note, for hemoglobin electrophoresis, you are going to consider that most commonly what we do is cellulose acetate electrophoresis. Cellulose acetate electrophoresis, which is done at a pH of 8.4, matlab basically alkaline pH pe karte hai. That is what I've analyzed. Most of the cases you're going to do that only. So first I will refer to only this part of the electrophoresis. The pH 8.4 is the cellulose acetate electrophoresis. And for this, what are you going to know? You all will have to learn this diagram. And what is this diagram? In hemoglobin electrophoresis, so I will label this as hemoglobin electrophoresis, you have one end. Electrophoresis always works on charge, na? So one end is going to be the anode and the other end is going to be the cathode. So that means that the anode is going to be positive and the cathode is going to be negative. Okay, basics. Now we have learned I've seen most of the students learn one mnemonic called HAFSA. What is the HAFSA mnemonic? The HAFSA mnemonic is that the first hemoglobin, which is not shown here because वो normal नहीं होता, very rarely is it seen, that is hemoglobin H. The first hemoglobin band that you see is hemoglobin H. Then you see adult hemoglobin, then you see fetal hemoglobin, then you see S, sickled hemoglobin, then you see A2. Now everyone's understood what is the HAFSA mnemonic. So we have hemoglobin H, hemoglobin A, hemoglobin F, hemoglobin S and hemoglobin A2, and this is going to go from anode to cathode. But now I also see some other hemoglobins. I realize that S and D tend to overlap. Baki nahi padho, just read S and D. S and D tend to overlap. So if I get a band in this area, either it could be a case of sickle hemoglobin or it could be a case of hemoglobin D. So how do I differentiate whether it is a case of sickle hemoglobin or hemoglobin D? I will tell you, because now you will have to do a little bit of acidic pH. Now you will have to use citrate electrophoresis. Citrate electrophoresis matlab citric acid means the pH is going to be a little acidic. The pH is going to be somewhere around 6.2. Basically is going to be a little acidic, and that ways S versus D ka band is going to split up. Sickled and D is going to split up. That cannot split up on a cellulose acetate electrophoresis on an alkaline pH. So this was cellulose acetate electrophoresis. That is why the S and D were coming as a common line. So S and D is going to overlap. Finally, with A2, I can see a lot of other things overlapping, and A2 is present near what? It is present near cathode. So they ask you a simple question, what all is present near the cathode? So cathode mein C hai, so hemoglobin C is present near the cathode. AT, so I've learnt it as A2. A2 is present near the cathode. Then we have E, O, Arab. So O, Arab is present near the cathode, and E is also present near the cathode. Yaad ho gaya? So cathode ka mnemonic is cathode. C for hemoglobin C, AT for A2, hemoglobin O, hemoglobin E. All of them are going to be present near the cathode. So whenever you have to go from anode to cathode, you will learn the mnemonic Hafsa. That is, you have hemoglobin H, hemoglobin A, hemoglobin F, then hemoglobin S. S is going to overlap a little with D also. And lastly, you have hemoglobin A2, and A2 is going to overlap at the cathode with a lot of things. If in the exam you Hafsa and all sab kuch bhool gaye, you forget everything. Suddenly you go blank. What can help you in the paper then? Remember, the main concern will be, please differentiate between sickle cell anemia. Main question that will come will be on sickle cell anemia. So in the exam, just in case you forget, I'll give you one trick. I'm going to draw 3 rectangles and let's see if you can analyze it. In all of them, one end is going to be the anode and one end is going to be the cathode. So sab mein same way, one end is anode, one end is cathode. I put the hemoglobin over here and I say, usually we start off from the cathode end. So if I put the hemoglobin over here and I say that all of the hemoglobin went till the anode, the band is formed over here, all of the hemoglobin has gone to the anode. This is patient number 1. In patient number 2, all of the hemoglobin has stayed at the cathode only, over here only. It did not travel much, it stayed here. And in the third person, little bit of the hemoglobin stayed here and little bit of the hemoglobin stayed here. So how will you differentiate? You will say, ma'am, that Hafsa mnemonic is not coming to my mind. I'll tell you. See, you always remember Hafsa mein adult hemoglobin always stays near the anode. So when over here only and only adult hemoglobin was there, this means this was a normal person. On the other hand, जो sickled hemoglobin होता है, the sickled hemoglobin that you have, that is said to be very, very slow. Very, very slow means it is going to be put here and it shall remain here only. It was put over here and it remained here only. So sickled hemoglobin is very slow. This person has all of sickle hemoglobin, means this is a case of sickle cell anemia. And finally, this person has little bit of slow wala sickle hemoglobin, little bit of A wala adult hemoglobin. So this must be HbAs, means this is a case of sickle cell trait. Have you been able to analyze that adult hemoglobin will be at anode and slow wala hemoglobin will be at the cathode? So let's make you do some interpretations. What do you think is our patient number 1, patient number 2 and patient number 3? Ye kya hai? So you will say all of them have only adult hemoglobin. So I will label them as normal. Adult hemoglobin matlab normal. Okay. Asking you the next, what is this band? This patient is what? In this patient, I see it's an overlap wala situation. Either it's a case of HbSS, matlab sickle cell anemia, or it is a case of HbDD. What are you going to do? Remember, you're going to change the pH and you're going to split it up. Easy. Coming to the next, band is only over here. Next patient only over here. Next patient only over here. So kya hoga? You will say these are all normal bands. These are all normal patients, ma'am, that you are doing. But answer this now. What is this patient showing you and also what is this patient showing you? You will say they have little bit of adult hemoglobin, little bit of adult hemoglobin, little bit of sickled hemoglobin is there. So are they examples of sickle cell traits because they're heterozygous? Samajh aa gaya? Coming to the next, this person has little bit of sickled and this person also has little bit of C. SC, this is that compound condition, double problem hai. Hemoglobin S is also there, hemoglobin C is also there. So I'm basically trying to show you that this hemoglobin electrophoresis can diagnose n number of hemoglobinopathies for us. And you can change the pH, and you can also differentiate between sickled and D also over here. However, even now, I am not very convinced because this is not showing me accurate results. Some overlaps are there, quantity I'm not getting to know. So now when they ask you, what is the gold standard for hemoglobin disorders, it is HPLC. It is high pressure liquid chromatography. It is said to be high pressure liquid chromatography. I'll show you how a high pressure liquid chromatography graph looks like. This is exactly how it looks like. So you will realize that there are peaks of hemoglobin that are seen. Different hemoglobins, adult hemoglobin, sickle, they come at peaks. And what peaks? They are at different times. So these are said to be the retention times. You don't have to learn it before you feel that, oh my god, what is this table? No. This is just to show you that you're going to get different peaks. Like fetal hemoglobin ka alag peak hai. Then for adult hemoglobin, you have a different peak. For A2 hemoglobin, different peak. For sickle, different peak. For D, everything has a different peak, and that depends on the machine. After how much time is it going to get eluted? So remember, on the basis of that, we have these different peaks that are defined, and that is how you do the diagnosis. That is how the diagnosis is made. So remember, this is just to give you an idea that HPLC ka graph looks like this. Doesn't mean they'll give you graphs to identify the paper, and even if they do, they will label it. They will label कि अच्छा this peak is of S, so you will know अच्छा sickle cell ऐसे होगा. They label that graph. So coming all the way back, this is the case of HPLC, which is the gold standard of any hemoglobin disorder, be it sickle cell or even thalassemia. HPLC is the gold standard for all hemoglobin disorders. Done with this, what is the last point? Of course, the treatment. Now, sickle cell anemia is a genetic problem. I can't do much about a genetic problem. It's happened. But what I know about sickle cell anemia is that if I keep the oxygen levels good, patient will not have a problem. Hypoxia mat hone do. So what do? I give a treatment, and that treatment is known as hydroxyurea, because hydroxyurea is a drug that elevates your fetal hemoglobin, and if the fetal hemoglobin is elevated, the oxygen levels are going to be good. Hai na? So please remember, you are going to give the patient hydroxyurea. That will increase the fetal hemoglobin, the oxygen levels will be good, and your problem is solved. That wraps up our discussion of